Well, hello and welcome everyone. Thanks for joining us at our Facebook Live event today, Looking After Little Lungs, a partnership between the Centre for Research Excellence in Newborn Medicine and the Life's Little Treasures Foundation. My name's Brett Manley. I'm a consultant neonatologist at the Royal Women's Hospital. So my job is to look after unwell and premature little babies in our neonatal intensive care unit for as long as they're in our hospital. But I also look after families before babies are born in order to prepare them for the birth of their child, and also up until they're about 2 years of age. We like to follow our babies at least for a year or two to see how they're developing. And with me today is my friend and mentor, Professor Lex Doyle. Lex, could you introduce yourself?
Thanks, Brett. Welcome, everyone. My name's Lex Doyle. I'm a neonatal paediatrician who started to look after babies back in 1975 for the first time at the old Women's Hospital in Carlton. At that time, we were just starting to use ventilators to help babies to breathe, and prior to ventilators, most little babies with big breathing problems just died from exhaustion after a day or two. There wasn't much we could do about it. But the machines came along. We didn't really know what we were doing with them to start with, but gradually people developed the skills to help keep more and more babies alive. There are lots of other changes going on around that time, including the introduction of corticosteroids given to mothers to help improve lung maturation, and they made a big difference. And then later on, we were able to use a medicine called Surfactant, which Brett will tell us about shortly. So over the more than 40 years I've been looking after little babies, I've seen big changes in terms of survival and long-term outcome. I stopped working in the nursery about 12 years ago, mainly because I was too busy with research, and what my research has focused on has been looking at the long-term outcomes for those little babies who survive, and that includes following them through childhood and now into adulthood, and that's been very rewarding, and I'll tell you a little bit about some of the results from that research shortly.
Well, thanks, Lex. We're very lucky to have you here today to tell us about long-term follow-up and development of our preterm babies. So as I mentioned, today's session is a partnership between the Centre for Research Excellence in Newborn Medicine and Life's Little Treasures Foundation. It's the first of what we hope will be many such events that we're calling the Prematurity Roadmap, information and question and answer sessions for parents of premature infants. And today we're talking about lung health, particularly of preterm infants, both whilst they're in the nursery, the sorts of problems they might have and how we might treat those, and then just as importantly or more importantly, following them up after they go home from hospital and the sorts of things parents might need to know about the health of their preterm babies after leaving the hospital. As we talk today, you'll have the opportunity to post your questions on the Facebook page, and we really encourage you to do so. At the end of our presentation, Lex and I will try and answer as many of those as we can. And if there's any that we don't get to, we'll continue to try and answer those over the coming days and weeks. So please, if you think of something after today's session or you're watching it later on the net, then please send those comments through and we'll do our best to respond. So we're going to start the session today with a few slides. Firstly, I'm going to talk about what happens with little babies in hospital, and then Lex will take over and talk about what happens after they go home. So firstly, we're going to talk about what goes on in the neonatal intensive care unit. And we spend a lot of our time in the NICU looking after babies with what we call respiratory distress, which really just means breathing problems. And how we tell if a baby has respiratory distress is to look at them, their physiological signs, and to examine them. The first thing we look at is a baby breathing too fast? And newborn babies breathe faster than children or adults do. When they're first born, they might breathe at 40 or 50 or 60 breaths per minute, but anything more than 60 breaths per minute, we think that might be too fast. We also look at them and try and tell whether they're working harder with their breathing, and the sorts of things we look at are they having to make extra noise when they're breathing? Are they sucking in under their ribs or between their ribs that might show that they're needing to use more of their muscles to breathe? Noisy breathing can also be a sign of respiratory distress, either with a problem in the upper airway or down in the lungs. And of course, low oxygen levels or turning blue that we call cyanosis is a sign that not enough oxygen is getting around the baby's body. And there are many causes of respiratory distress in infants that we look after in the NICU, some of which are listed here. That includes an acid buildup around the time of birth, caused by a lack of oxygen or blood supply, that their temperature is too low or too high, and we have to be very careful with monitoring and maintaining newborn babies' temperature in the first hours after birth. They might have an infection, and we commonly treat babies with breathing problems with antibiotics. There could be fluid in the lungs, particularly after a caesarean section, but sometimes in babies who haven't had a caesarean section. There could be a problem called meconium aspiration, where actually the newborn baby's got into trouble before it's born and passed a bowel action and then inhaled some of that into the lungs. A pneumothorax is an air leak from the lung, commonly called a punctured lung, and we see that not uncommonly. And of course, there are many congenital problems, such as heart problems or lung problems, that can cause breathing issues. This is a chest X-ray that those of you who've had babies in the NICU will be very familiar with, and we commonly use X-rays to monitor how babies' lungs are inflated and also to try and make a diagnosis of why they're having breathing troubles. I've labelled here the lungs on the outside on both sides, which are the darker areas, and these are quite healthy looking lungs actually, nice and dark. In the middle, the white blob there is the heart, and the darker white areas up the middle are the spine. In fact, this baby has had some trouble despite having lungs that look quite healthy, because I can see a breathing tube in place there, which means that this baby's been receiving mechanical ventilation in the neonatal unit. And here are some other chest X-rays as an example of how different they can look when babies are having trouble. On the left in the top left corner there is the X-ray with the normal lungs, and then down below on the left-hand side you can see lungs that are not looking as black. They look white and quite dirty, and that's a baby who's had trouble with meconium aspiration. And then on the right-hand side, the lung there looks even darker on one side than the other, and that's actually too much air around the lungs, and that's a pneumothorax or a punctured lung that needs treating. But when we talk about preterm babies, we're talking about a very common breathing problem called respiratory distress syndrome, or RDS. And this is a breathing problem that we spend a lot of our time treating in the neonatal intensive care units, and that's mainly because preterm birth is now becoming so common. In different countries, between 8 to 12% of all births are now preterm, before 37 weeks gestation. And when we're talking about the neonatal intensive care unit, we're often looking after babies born even much earlier than that, sometimes very preterm, before 32 weeks of gestation, or extremely preterm, before 28 weeks of gestation. And the earlier babies are born, the more breathing problems they tend to have. And this is mainly due to this respiratory distress syndrome, which is a combination of having immature lungs and also a lack of a very important substance called surfactant in the lungs that we all have. And the job of surfactant is to coat the smallest airways and stop them collapsing. So if there's a lack of surfactant in the lungs, the very smallest airways that are important for getting oxygen in and carbon dioxide out are not inflated and therefore not working as they need to be. And some infants can cope without enough surfactant, and others can't. And this is just a diagram that Lex made up showing how surfactant can work, and this is supposed to be a small airway here with in white, and the surfactant molecules sort themselves out around the wall of the airway and push back on each other and keep that little airway open. And we know that the more premature you're born, the more likely as a preterm baby you are to have breathing problems, and also boys tend to have more trouble than girls. And conversely, protective factors include being more mature, and the more mature that you're born, the less likely you are to have breathing troubles from respiratory distress syndrome. And also importantly, we know that antenatal corticosteroids, these are the steroids injections given to mothers before preterm birth if there's time, are very protective and really improve babies' chances of surviving and reduce the risk of having bad lung disease after they're born. So antenatal corticosteroids, Lex, have been around since the 1970s.
Yeah, the late 70s we started to use them more and more in Melbourne, and we were one of the first centres in the world that started to do that. And they really dramatically changed the outlook for some of these little babies, because a lot of them were born and they didn't really have too much problems with that surfactant deficiency, so they didn't really need too much support at all. So that really changed things quite dramatically. I think it's important to point out to people listening that these steroids are not the sort of steroids that the bodybuilders use or athletes might use to try and make themselves stronger. These are a different type of corticosteroid. They're anti-inflammatory, but in this instance what they do is they help the lungs to switch on earlier to make this surfactant. Normally babies will do it around 34 to 35 weeks of pregnancy. Normal pregnancy is up to 40 weeks, but if you're going to be born before then, giving the corticosteroids to the mothers will help switch on that production in the fetus, and so then when they're born they don't lack that surfactant.
So I think along with surfactant, antenatal corticosteroids are one of the big advances in neonatology in the last 40 years and really have saved a lot of lives. So for a few injections to mum before their baby's born, it really has a fantastic benefit.
Yes.
So here's a chest x-ray. Now again we've got a normal looking chest x-ray in the upper left hand corner, and then this is in the middle of the screen a chest x-ray of a preterm baby with RDS, and you can see the difference there, the lungs looking much whiter. And we also look to see how well expanded the lungs are, is there enough air getting in, and how much fluid is in the lungs as well.
So what the whiteness means to people listening is that there's not much air in the lung. Those airways have collapsed, air's gone, replaced by white, and so that's what we can see on the x-ray.
So lungs should look black because air looks dark on the chest x-ray.
Because they're basically full of air. So
we've talked a little. We've mentioned how we look after babies in the NICU a little bit, but here are some little babies, a very small baby on the right receiving what we call mechanical ventilation. So this is where we need to put a breathing tube down into the windpipe or the trachea, and babies are on a machine that helps them to breathe. And as Lex mentioned, mechanical ventilation has been around for 30 or 40 years, but when we first started ventilating babies back in the 70s, things were pretty crude.
Yes.
I'm pleased to say that we've come a long way with the way that we can mechanically ventilate babies now. We've got newer technologies, and the machines are much cleverer in the way that they particularly allow the baby to breathe for themselves. So if a baby wants to breathe, he or she can. If they need a bit more help, the machine can help out. So technology is advancing, but still we do know that we would rather avoid mechanical ventilation if we can. Even though we're much better at gentle ventilation, we still know that the longer babies are on a mechanical ventilator machine and the higher the pressures that they need to inflate their lungs, it can actually contribute to longer term lung disease. So we try very hard to avoid this. The one issue there is that to give surfactant, which many of our preterm babies need, the most common way to do that, and at the moment, is to give it down a breathing tube. So there's no avoiding putting a tube down into the windpipe for those babies who need surfactant, although we are looking very hard at ways that we might be able to do that more gently.
So Brett, the listeners might want to know that we started to use surfactant in 1991. We heard about it through the 80s, but we didn't have any in Australia. But in 1991 we could get it, and the first baby in Australia was treated in the Royal Women's Hospital in 1991, and that really changed that natural history, if you like, of the problem of RDS, because the trick was, before we had surfactant, to keep the baby alive long enough, because we knew after a few days they'd start to make it themselves, and then after another 4 or 5 days the original lack of surfactant would cure itself. But by giving it soon after birth, that shortened all of that quite dramatically. And so the x-rays you've shown of the really white lungs, we virtually never see it today, because the babies are born, if they need the surfactant they get it before the chest x-ray is done, and by the time the x-ray is done the lungs look nice and black. So we hardly ever see those white looking lungs anymore. It's completely different to what it was in the 70s and 80s.
And for many babies it's really amazing how quickly the surfactant works, isn't it?
Absolutely,
When
yes.
they're born and they need a lot of oxygen and a lot of help with their breathing, then the surfactant squirted down into their lungs, literally just squirted down,
Yep,
isn't it? And
that's right.
And immediately we see an effect where the need for oxygen comes right down, and the need for support
And
comes
this is
right
in
down.
minutes. Yeah,
Within
that's right.
minutes.
Yeah.
Yeah. So one way that we can avoid mechanical ventilation is by using different types of breathing support, particularly into the nose. And for those of you who've had babies in the neonatal intensive care unit or special care nursery, you might recognise these forms of ventilation. On the left-hand side there we've got something called nasal high flow, and on the right-hand side we've got something called nasal CPAP. And these are what we call non-invasive forms of ventilation, that is that they're in the nose and they don't require a breathing tube to be inserted. And we now know from a lot of clinical studies that even the smallest babies can often be supported with these types of breathing with the aim to get away without using mechanical ventilation at all. But still we find in our smallest, sickest babies, we still need to give surfactant down a tube into the windpipe, and often with a period of mechanical ventilation. So what's the end point of all of this? Well, there's something called Bronchopulmonary dysplasia, or BPD, and we like to just call that chronic lung disease of prematurity. And here's another chest x-ray. Again, this is in an older preterm infant that's been in the neonatal unit for some time. Again, what we're seeing in the lungs here is a lot of white instead of a lot of black. And what that's representing now, instead of what I showed previously, which was respiratory distress syndrome, this is now the scarring and inflammation associated with chronic lung disease of prematurity. And we know the smaller and earlier babies are born, the more troubles they have in the first weeks of life, the more likely they are to have this chronic lung disease. And for us, chronic lung disease is a diagnosis made at a point in time, which is when babies are 36 weeks post-menstrual age. And we use that as a marker or a surrogate for lung disease, how bad their lungs have disease has been and how likely they are to have problems in the future. It doesn't mean they will, and many babies recover after having chronic lung disease, but we still use it in all of our research studies as an important marker of what's going to happen later on.
So Brett, again, I think for people listening that probably about half of the little babies who are most immature, under 28 weeks, will end up with this problem at 36 weeks, but the other half won't. So question of whether the glass is half full or half empty. So as you say, we'll talk a bit more about the longer term outcomes of this condition in a minute.
And a big problem for us as the doctors and nurses looking after these patients is we can't predict which ones are going to get it.
No, that's right.
Sometimes we have a fair
not
idea.
at birth anyway.
Not at birth.
As they're getting older, we can work out which way
Sometimes
they're
even in the little babies who do quite well in the first days and weeks of life, they can still end up with this problem.
That's right, yes.
So it's a real issue for us, and ideally we want to prevent BPD or chronic lung disease. And we know that some things work, but really there are very few therapies that are known to prevent or effectively treat BPD. We know that if we keep babies off the mechanical ventilator, that's a good thing, and using gentler forms of ventilation might help. There's also something that Lex has been heavily involved with, which is that any of you who've had babies in the neonatal unit will know that we treat many of them with caffeine, with coffee essentially. And there's been big studies showing that caffeine for little babies helps them to remember to breathe, keeps them their brain stimulated to breathe, but unexpectedly has long-term health benefits as well, and we might be able to talk more about that later. And we've mentioned antenatal steroids given to the mother before birth, but unfortunately they don't prevent chronic lung disease, but we can give similar forms of steroids to the babies themselves after they're born. And we know that that has both good effects, but also some side effects, and we have to be very careful about how we give those steroids. So a lot of our research is looking at how we new methods of preventing or treating BPD, such as new ways of giving steroids, other anti-inflammatory drugs that might be useful, and more recently stem cells have become a hot topic in our profession to see whether they can help repair the damage in the lungs or prevent it from happening in the first place. All right, so I've talked about what happens in the neonatal intensive care unit, and now I'm going to hand over to Lex, who's going to talk about issues after premature babies go home.
Thanks, Brett. So there are a number of things that I'm going to cover in this talk. Firstly, some of the babies go home on oxygen. There's the issue of being readmitted to hospital after you've gone home. Immunisations are important. A little bit about general health, and a little bit about long-term breathing ability. So these are the areas that I'll cover. So home oxygen. Some of you may have had your baby go home on oxygen, so you'll know all about it, but others won't know about this. Some babies do remain on oxygen for quite a long time, and they're otherwise ready to go home. In other words, they're big enough, they're feeding well enough, they're not doing anything else wrong. It's just that they're on a little bit of oxygen and it's keeping them in hospital. And so what happens is, for some of those babies, we need to show that if the oxygen was disconnected, they would be able to cope for a period of time, just so that they wouldn't, get really very sick in the short term. If they pass this test in air, then they will be sent home on oxygen, and this is managed through the Royal Children's Hospital, but we might have them at flow rates that are pretty low in the hospital before going home, like 50 mils a minute, 25 mils a minute, something like that. But when they go home, the machines that deliver the oxygen can only deliver a minimum of 250 mils a minute, which might sound a bit strange. In other words, the oxygen goes up. They come back to the Children's Hospital usually about once a month. They check out how things are progressing, and when they think that they might be ready to come off the oxygen, usually the babies are admitted overnight for a period of oxygen monitoring, and then if they cope well in air, then the oxygen is stopped. And this might take place several months or even quite a bit longer after they go home. Going back into hospital is quite common, unfortunately, for all babies. So whenever we talk about little babies, we need to think about what happens if they weren't little, because you need to have a baseline for comparison. So babies born on time or at term certainly end up back in hospital as well after they're born. And this just shows you, I'll just show you some data on graphs, and about 1 in 6 or 1 in 7 babies born at term will be admitted to hospital between going home after delivery and about 2 years of age. So 1 in 6 or 7. So it's pretty common. So if you've got a baby born on time, they could end up back in hospital. One of the commonest reasons, a group of reasons, is they've usually got medical problems, but occasionally they need surgery. A lot of the medical problems, breathing difficulties are one of the commonest reasons, and of the surgical reason, genitourinary operations, hernias in the groin or testes that haven't been descended. These are the commoner types of operations you see, and they occur obviously more commonly in boys. Now, if you're a very preterm baby, you're much more likely to end up back in hospital. In fact, over half of the babies under 28 weeks end up back in hospital between going home the first time and 2 years of age. And just there in red, you can see the comparison group in blue. And the medical reasons are by far and away the commonest problem. And of the medical reasons, it's usually respiratory illnesses. So they're getting breathless, they're wheezing, they can't cope at home, they have to come into hospital. And that's the commonest reason they end up back in hospital. The surgeons also bring them back into hospital, and the genitourinary surgery is much more common, and the little boys who are extremely preterm have a lot more hernias in the groin and they need operations. About 1 in 3 little boys will end up needing a hernia operation in the first few years of life. It also happens in the little girls as well, surprise, surprise, but that's around a rate of about 1 in 30. Between 2 and 8, this going back into hospital continues on. So again, over half of the most immature babies end up back in hospital, compared with about a quarter of the babies born on time. Here the reasons start to change a bit. Here it's the surgery rather than the medical problems for both groups. And of the medical problems, again, respiratory problems are the dominant reason in the preterm babies. And the surgery, it's usually the ENT surgeon, and the commonest operation they do is putting in grommets into the ears or ventilation tubes into the ears, in particularly preschoolers, so that can help them to hear better so that they can learn to speak better. So that's a pretty important operation. But you can see everything happens more frequently in those who are very prem compared with those born on time. But the term babies also have a lot of problems. If your baby did have the BPD we were talking about, or the chronic lung disease, they're more likely to end up back in hospital than if they didn't. And you can just see that the red is the BPD and the blue is the non-BPD. In every group, apart from the genitourinary surgery, those who had BPD are a bit more likely to end up back in hospital over those first few years, and also between 2 and 8 years of age. Immunisations are very important. This is one thing that we don't correct for prematurity, and the reason I mention this is whenever we look at the little baby after they've gone home, we always have to take off the number of weeks of prematurity before we look at their size and how they're developing and whatever. But this is one thing that is not adjusted for prematurity. In fact, it's the only thing that's not adjusted for prematurity. And the current Australian schedule for all babies, and this includes the most immature babies as well as the big babies, soon after birth, in the first day or two, all babies get an injection to protect them against hepatitis B. Then at 2 months, they get 2 injections of one medicine, and there's a list of diseases there. The second one, diphtheria, that's a really nasty disease that even I haven't seen. I'm not old enough to have seen that, because that's really been basically eliminated by immunisation. Similarly with tetanus in this part of the world, we don't see that. That's not really respiratory, but that's a disease that attacks the muscles and can kill you. It does occur in the developing world, where they do things like putting cow manure on the baby's umbilical cord and the germ gets in and causes big problems, but we don't do that in this part of the world. Whooping cough we do see a lot of, and it still occurs despite immunisation. The whooping cough immunisation is the most controversial bit of the immunisation schedule, I guess, because it probably causes a little bit more reaction than the other parts, and it also isn't 100% effective at preventing whooping cough. But you're better off getting that immunisation than not, because the whooping cough disease, if you're a little baby, it's not really very good.
Can I just emphasise, Lex, we definitely still get babies through our neonatal intensive care unit with whooping cough, and
Yes.
and for those of you that have seen whooping cough, you definitely don't want your little baby to get it, and I think it's just so important that we all
Yes.
we all get our babies immunised for pertussis, but also for parents who are looking after preterm babies, or for grandparents that are looking after preterm babies a lot. It's very important that they go out and get the pertussis vaccine.
Yeah, so that's the whooping cough pertussis vaccine, as Brett says. So all of us caring for little babies should do that, make sure we're fully immunised, and we should also get the flu vaccine. So we're not passing on the flu virus. Polio these days is now back in injection form. I remember as a child at school, kids were queuing up and getting injections for polio, and then they changed to a medicine that was on a spoon, and now they've gone back to the injection form. The last one on that list, HIV, Haemophilus influenzae B, in the 70s when I was looking after children of all ages, that was the commonest cause for meningitis, and that was a really nasty infection. It also caused bad lung problems as well. But these days we can pretty much prevent that completely by the immunisation with the Haemophilus influenzae B. One that's just being introduced on the next line is pneumococcus. That's also a lung germ, and it causes nasty pneumonia. Not that common, but worthwhile not getting it. And then another one that's relatively new is rotavirus. When I say new, it wasn't around in the 70s, but it has been introduced in more recent years. And rotavirus is the commonest cause of diarrhoea in little babies, and that's certainly worthwhile protecting your baby against. 4 months, those immunisations are repeated. Then at 6 months, you can see it changes a little bit. There's only 1 injection rather than 2 injections and 1 medicine. At 12 months, measles, mumps, rubella. Measles I saw a lot of in the 70s before the immunisation was available. And that's a very nasty disease. It causes misery for a good week, and if not 2 weeks. And it was causing a lot of babies, a lot of children, I should say, to end up in hospital, and some of them would die, unfortunately. And it also had other rare, longer-term complications, particularly affecting the brain. So it's really good that we don't really see much measles anymore. Mumps has always been around, and rubella, which is German measles. That's a very nasty problem for little babies to get before they're born. The next one, meningococcus. This is a disease you hear about occasionally, where an older person, or it could be a child, or it could be an adult, all of a sudden gets acutely unwell, and they can go from being perfectly well to dead within 6 to 12 hours. It's such a virulent, very nasty infection that if we can prevent that, we should. And then the pneumococcus, again, we talked about that earlier. At 18 months, we get some boosters of some of these, and then at 4 months, we get some more boosters. So all these immunisations, some of them are directly targeted at lung problems, which is what is the topic for today, but also general health is pretty important as well. What about general health compared with children born at term? Those who are born most preterm do have more coughs and colds, and they end up more commonly with a disease called croup, and that's sort of like laryngitis, but in young children, those who are a year or 2 in particular, the voice box, just below the voice box, is relatively narrow, and when that gets inflamed with whatever the cough or cold germ is that's causing it, they tend to then have trouble breathing in. They make a noise and go, they make a sound like that, and that can be quite distressing for the child and also for the family. But as they get older, they grow out of that problem. They end up certainly with more ear infections because the tube that's draining the middle ear into the back of the nose gets blocked up, and this is a common reason why you have to take your child to the doctor. They get more wheezing illnesses, and we talked about them having those problems ending up back in hospital. Is asthma more frequent in ex-preterm children as they grow up? In some studies it is. In most of our studies it hasn't really been, but asthma is a common problem. So 1 in 5 children end up with recurrent cough and wheeze, and in very preterm babies it's about a similar rate whenever we've studied them in the local population.
Can I ask a bit more about that,
Yeah,
Lex? We've
sure.
got actually a question has come through from Melissa Dunat. Welcome, Melissa. So is there research in regard to babies with chronic lung disease and asthma? So what do we know? How much more likely is it that babies are going to be diagnosed with asthma? And when do they get diagnosed with asthma? That's a really common question from parents. When can you diagnose it?
So the diagnosis of asthma is tricky. It's recurrent cough and wheezing. So if you just have one episode of cough and wheezing and getting breathless as a little child, usually that won't be called asthma. But
So some babies are wheezy and then that gets better.
and that gets better. Or they can have just one episode of a virus that particularly causes cough and wheezing, and they may never get it again. But if they have recurrent, and how many is recurrent, is 2 enough or 3 enough or 4 enough? It depends a little bit on who's seeing them and how often it is occurring, but then the label is often put on. Now, the thing about younger children is the sort of asthma medication that you might use in older children or in adults don't tend to work particularly well, because most of those medications that help make the tubes a little bigger don't really work, because there's not a lot of muscle in the airway in the youngest babies. So that's why they're not used, and that's probably why the label isn't put on. But as the child gets older, they become more responsive to those medications, and so the label of asthma will be put on the child. Most asthma is recurrent, and in between the episodes you're quite well. But occasionally it is more persistent, and some people have more breathlessness most of the time rather than just intermittently. So, but in the ex-prems that we see, they seem to have as much asthma as we've seen in the children who haven't been ex-prem. But in other parts of the world, they describe a bit more asthma rates. They grow more slowly in early childhood. They're often relatively underweight, but then they catch up later on. And they do have more developmental problems. But this is really a topic for another day, but I'd mention it here in case somebody wants to raise it as an issue. The last slide I'll show, or one of the last slides I'll show you, is a little bit about long-term breathing ability. One of the things I've been doing is to, with our team, is to measure how the lungs are growing and how the air gets in and out of the lung. And if we look at how the lungs grow over time, over the first 20 years or so, our lungs grow, and you can measure this in terms of how much air gets out of the lung from about 3 years onwards, and it reaches a peak in your early 20s. Some people have bigger lungs and some people have smaller lungs, so there's always a bit of variation. But after we reach that peak, around about 21 or 22, it's all downhill from there for all of us. So I'm far to the right here, so I'm further down the slope than you are, Brett, because you're a young man. But, you know, this is the fate for all of us, if you like. Our breathing ability diminishes. In other words, I can't run as fast as I could when I was younger and that sort of thing. Now, for most of us, and most people in old age, it's not going to be a problem. We're not going to get breathless, just doing nothing, because our lungs will still be big enough. And we're not going to die from our lungs getting sort of too small or the breathing ability becoming too little. But if, of course, we're smokers, and if we start smoking earlier, or if we start off with lungs that are smaller, well, then we can get into trouble. So smoking is one really nasty thing to avoid. Now, the thing that's happening with the preterm children, when we've studied their lungs, you can see in the red here, on average, their breathing ability is reduced. And we don't really know what happens to them beyond about 30 because they haven't lived in big enough numbers. The survival rates only went from less than 10% in the 60s to 3 and 4 now for the smallest babies. So they haven't been around long enough to actually study out into the 50s or 60s or 70s. So the red line's a bit of a guess.
This is a big issue, isn't it,
A
with
big
our
issue,
follow-up,
yeah,
Lex?
that's
We're
right.
doing the best we can, but it's only in the last decades that we've had really little tiny babies surviving, and
That's
so
right.
we are actually trying to follow them through to adulthood, but
Yes.
it's going to take much more time until we know what happens when they're much older.
Exactly.
Yeah.
Of the small babies who end up with the smaller lungs, of course, then some of them might start to get to levels where they might start to get breathless at rest in their 70s or 80s. And of course, if they start smoking, heaven help them, because that it can only make their lungs worse. It can't make their lungs better. Now, if they had the BPD, we know that the breathing ability is a little bit reduced. So that's a disadvantage. So those who had BPD as little babies, as adults, might end up with more breathing difficulties in later life. We've seen them up to the mid-20s or the late 20s, but we're trying to follow them into their 30s and their 40s. But it won't be me who does that, or the young people like you or your colleagues who end up following some of those people out into later adulthood to work out what the really long-term outcome is. But at this stage, it's a bit of an unknown. What can parents do about it? Well, smoking, little kids follow their parents, so if parents are smoking, they're going to tend to copy them. And we know that ex-prems who smoke are more likely to do so if there are smokers at home. So set an example for them and don't smoke is one thing I can recommend. So these are the areas that I've covered, and I think that finishes our formal presentation for today, so I'll just switch that off.
Well, thanks, Lex. A lot of good feedback coming through about the way you talked about the long-term breathing outcomes there. I think we've got a bit of time now to start answering some of the questions coming through and comments coming through on the feed here. Megan Montgomery is online. Hi, Megan. I'm pleased I can't believe your twins are 8 years old now. They were 24-week twins that we looked after at the Women's Hospital. Megan's asking, a lot of our babies end up with this chronic lung disease label. Especially, well, you've mentioned the babies born under 28 weeks, we call them extremely preterm infants. About half of them end up with that diagnosis. And her question really is the technicality of, is that a disease? When does it stop being a disease? And what happens after that? I can probably go some way to answering that. The first thing to say is that we are moving away from calling it chronic lung disease in our research and in our publications now, and we're more often calling it bronchopulmonary dysplasia to really reflect what's going on inside the lungs pathologically. It is a diagnosis made at a point in time at 36 weeks gestation, which we then use in our research to compare babies into the long term, whether they had BPD or chronic lung disease or didn't. So in terms of what's happening in the lungs after a diagnosis of chronic lung disease, can you comment any more on that?
So back when I started looking after babies in the 70s, we saw babies develop the really nasty scarring type of lung disease that you showed earlier, with the lungs looking very white. Those lungs were, when I say scarred, they were injured, the airways weren't growing properly. That's called dysplasia, meaning disordered growth. And there was a combination of that with a bit of infection thrown on top that really made the lungs look pretty horrible. What we're calling BPD today doesn't look like that very often. It's more general haziness, and there seems to be the airways just stop growing at the same rate, and it seems to be more reduction in numbers of airways rather than the actual scarring and those sorts of things we see. But we still call it this, we still give it the same label. But I agree with you. I think the chronic lung disease label is probably not so good, because chronic lung disease implies permanence, whereas bronchopulmonary dysplasia describes better the disordered growth that's going on in the lung. Now, we don't know what's going on in the lung of the majority of children, because we don't want to get a bit of the lung to look at it under the microscope, because that's pretty invasive to do that. So we have to use indirect ways of studying it, and that includes x-rays or how much oxygen you need, that sort of thing. There are some fancier types of x-rays that people can do, but only really in older people, where they can cooperate with breathing tests and that sort of thing. We can't really do those tests in little babies very well. But we have to remember that little babies' lungs are not meant to be exposed even to air. I mean, if you think of a baby at 24 or 25 weeks into pregnancy, inside the uterus, the oxygen levels are extremely low, and particularly in the lung. There's hardly any oxygen molecules there at all. And then when they're born, all of a sudden they're exposed to air. We can't give them lower concentrations of oxygen than what's in air because they'll die, because they have to have enough oxygen to switch over the blood flow and everything else. They've got to get enough blood going to their lungs to get the oxygen in and the carbon dioxide out. If they can't do that, they're going to die, regardless of how well they're breathing and how much surfactant they've got and how much we're helping them with machines. So unfortunately, even air is going to injure the lung. So regardless of how much respiratory support, it's going to upset lung growth. That's why on average we're seeing the breathing ability diminished in ex-prems. Now most of them actually have lungs that are normal, that you can't distinguish from other people with normal lungs. But
I think that's really important to say.
It is
Many of these
important,
babies
yeah.
recover quite
Yep.
quickly, even though they have a diagnosis or a label of chronic lung disease. Yeah.
They're not symptomatic in the way that you can see the child struggling to breathe all the time. It's only when we do the breathing test we find that the airflow is a bit reduced. But most of them don't have breathlessness. They might not be as active and may be able to compete at higher levels athletically, but that's only a few % of the population anyway.
I think it's also fair to say that this diagnosis of chronic lung disease is somewhat of a controversial topic at the moment. People are saying, well, how can we arbitrarily say at 36 weeks gestation that a baby's got a worse lung problem than another baby just because they happen to be on breathing support or oxygen at the time? And there's certainly a movement to moving that back more towards term or even beyond before assessing a baby's lung disease severity. But it's the best we've got at the moment.
Sure, it's a convenient label, if you like, so we can get at least a benchmark to see how we're doing. Is it increasing? Is it decreasing? What's going on? But you're quite right. A lot of those children who may need a bit of help at 36 weeks, by the time they're ready to go home, they're fine, and they're not going to have any greater problems longer term, as we can best we can tell.
Okay, we've got a couple of questions that have come through about fish oil. Several parents, Crystal Smith here and Chloe Widlake as well, have asked about the fish oil studies that they've recently been a part of. The history of fish oil is that there's been a few big clinical trials that we've been involved with, haven't there?
Yeah.
Both of giving fish oil to mothers, which then gets through into the breast milk and is given to preterm babies. And there's been some signs that that might help to improve neurological outcomes and development, and that's why the studies were done. And then that was followed up more recently with a trial specifically looking at the lungs, because the first study showed, somewhat unexpectedly, that there seemed to be less BPD or chronic lung disease in some babies, and that was followed by another study called the NERO trial, looking at fish oil given directly to babies. And the questions come through, are we seeing problems with the lungs of babies that were in that trial? Now, the first thing to say is that if your baby was in the trial, I don't know whether they did or didn't get the fish oil, because that's how we do trials. But it was disappointing in that trial didn't show an improvement in chronic lung disease as we might have expected.
Yeah, that's true. That was the primary intent of that study, because the first study suggested it might work, but then the bigger, proper study was done and it didn't work, which is, as you say, disappointing. But I guess it puts an end to actually thinking that fish oil may help the lung. So that research has been very important over the last 15 or so years. That's been led by Maria McGreedy's and a team from Adelaide, and we've participated along with other people around Australia and other parts of the world in that research. It's very important that we know the answers to some of these questions so we can stop doing useless things.
Now we've got a really tricky question coming through. Let's see how we go. Rima Piriatinsky and others have asked about childcare. So they want to know, their babies are born extremely premature. They may or may not have had chronic lung disease, problems with their lungs, gone home on oxygen. What do we recommend about when they should start childcare? And I think the first thing to say here is I'm not sure there's a definite answer here. Some people would say not in the first years of life, avoid it altogether. Others would say it depends on how your baby's going. The fact is it's virtually impossible to completely avoid exposure to viruses or illnesses in the community, especially if there are older siblings involved. What do you say to parents when they say, when should I send my baby to childcare?
There's no right answer.
Yeah.
And it's a competing risk, if you like. I mean, presumably the child has to go to childcare so the parent can work, and that's important because you've got to get bread on the table and you know, you've got to live. So that's one side of the coin. children are born with a certain amount of protection against viruses, but that quickly goes away. That's passed on passively from the mother, but that's pretty much all gone within months. And then they've got to then produce their own protection, and that's what immunisations are partly about. But then there are so many other hundreds of viruses and germs that can cause illness that we just can't immunise against, and all the coughs and colds. Kids are going to get them inevitably, whether they get them as little children or when they're slightly older, inevitably they'll come. So if you have a first child and you don't have them in childcare, they may not get too many coughs and colds in the first year or two, but when they get to kinder, when they get to school, they'll pick them all up. And a new infection once a month is probably about the rate you expect through winter. Now, as you said, if they've got big brothers and sisters, they'll be bringing home the germs from kinder and school, and then the little baby will get them. So if they don't get them when they're little, they'll get them when they're later. I think the most sensible thing you can say is don't go looking for trouble, and importantly, don't let people bring trouble into your house. So, you know, if grandma wants to come over, or the relatives or the friends, and they've got coughs and colds, well, tell them to come next week. Don't come today. You know, give us a break. We don't want your germs. You have to be a bit diplomatic about this. People get offended, particularly grandmothers and grandparents, grandfathers, you know, oh, you can't come because you got a cough and cold. Oh, you know, I want to come, but we have to accept that, and just don't go looking for trouble. But you can't keep them wrapped up in cotton wool. You can't keep them in a plastic bubble. It doesn't exist. They're going to get it sooner or later. So there's no right answer. It depends on your other needs. Mm-hmm. Well, what do you advise parents?
Well, I think
you're a parent yourself, so
yeah, that's right. Well, the first thing to say is babies born at full term come home from childcare with a lot of coughs and colds, but obviously parents of preterm babies are worried about what the effects of that's going to be for them. It's individual basis. It depends on the patient in front of you. When a baby comes to see us in outpatients and they're an ex-preterm baby who've done very well, who've been healthy, who maybe haven't had chronic lung disease or have recovered very quickly, not needing any oxygen, growing well, looking robust, then we would, you know, usually say that that's a fairly safe thing to do, to go to childcare earlier, compared to the sicker baby that's got trouble breathing at rest, or
perhaps on home oxygen. Perhaps you might say, well, don't go looking for trouble. Yeah, and plus, I don't know how they would cope well with the home oxygen in childcare. That'd be a difficulty as well. Mm-hmm. Yeah.
Do we know anything about when the lungs become fully developed or fully grown? Tara Woods asked us, when do premature babies actually finish growing their lungs? And again, I think that,
good question.
Their lungs are growing all the time, and we see them in hospital, even in the intensive care unit. We see their lungs growing and developing, and for some babies they grow and develop relatively normally, and for others they have trouble with scarring and inflammation. I don't think there's any time that we can say 2 years or 3 years or 4 years that your lungs are fully grown, because our lungs continue to grow right up to adulthood.
Well, as I showed you in the slide just a few minutes ago, our lungs grow until we're about 21, 22, that sort of age, and then it's all downhill from there. What we don't know exactly is just whether the rate of decline for those who were born very prem is actually the same, or faster or slower. And if it's faster, then they're going to end up potentially with more lung problems in their 50s and 60s rather than 70s and 80s. But we just don't know yet, because they haven't lived long enough, they haven't been studied enough to just know what that trajectory is. That's one of the things we're trying to find out right now.
Well, interestingly, Marie McLean is online. Hi, Marie. She is 21 years old and was born at 27 weeks gestation, and she was on oxygen until she was 2.5 years old.
Right.
And she says she feels like sometimes she's struggling to breathe a little bit at the age of 21, and I guess we're not quite sure yet. Do we have enough babies yet that have been followed until they're 21 years old to see how they're doing compared to term infants?
Yes. Okay. One of the things I've been doing is collaborating with people around the world who have been studying breathing ability in young adults who are born extremely preterm or very preterm. And we've been able to get data on nearly 1,000 children who were of that age, sort of in their late teens to early 20s, and we've compared them with about almost an equal number of people who were born on time. And we know their breathing ability overall is reduced compared with those born on time. So we do know what they're like sort of around that age. What we don't know is what's going to happen when they're in their 30s and 40s and 50s. That just has to wait longer. If Marie's feeling a bit breathless, then that's the sort of thing she might want to consult her doctor about, because she might be the sort of person who could benefit from a breathing assessment.
Mm-hmm. Another theme that's coming through is the issue of coughing. Some of our parents are seeing that their ex-preterm babies have cough sometimes at night, or they just get a lot of bronchiolitis and a lot of coughing episodes when they get sick, and this is a big problem, and they're asking what treatments can we give or what can we do to prevent cough, and I think that's really tricky. You certainly need to be seeing your paediatrician or your GP to help try and diagnose whether that's a cough due to the lungs, a cough due to something else. Sometimes babies are refluxing with their feeds and getting a cough associated with that, but it's really hard to treat a cough, isn't it? Some of the asthma medications in older children where cough is a symptom of constricted airways from asthma can prevent cough. But otherwise it's really tricky. Some parents are using humidifiers overnight to see if that helps with the cough. Any other suggestions there?
Humidifiers are not likely to help a whole lot with a cough because the nose and the back of the throat will tend to humidify the air by the time it reaches the lung anyway. So actually adding extra water is not likely to help very much. If they want to use it, that's fine. It's not going to cause any problems. But you don't really want to be suppressing cough. It tends to be a protective thing rather than a good thing rather than a bad thing. It's just, unfortunately, it's the sign of something else, and it's the something else that needs the focus. And the focus often is a virus. Viruses can't really be directly treated. They have to run their course. So unfortunately, we have to put up with coughing children through the night, through the day, until such time as that virus has run its course and they get better, which is what happens to, by far and away, the majority.
One of the questions we've had previously about viruses is about something called RSV, which many parents have heard of. That's respiratory syncytial virus, and one of the commonest causes of bronchiolitis, which is a specific lung problem or viral lower respiratory tract infection that many infants get. And you only have to, we're sitting in the Murdoch at the Children's Hospital now, you only have to go down to the emergency department here or go up to the paediatric or respiratory wards right now and see just how many infants and children have been admitted with bronchiolitis.
Yeah, and that's at the peak of the epidemic is through the early, late autumn, winter, and we're probably in the middle of the epidemic right now. That's when it tends to occur.
And preterm babies are more likely to get those sorts of conditions, such as bronchiolitis, the most common cause being this RSV virus. So it can be a really difficult time, and we've got to be very mindful of that when we're discharging our preterm babies from the units. What season is it? Is it bronchiolitis season, and where are they going?
Well, you can't really change the time of the year that well, Brett. You don't want to keep them in the hospital for another 6 months just because it's the bronchiolitis season. I don't think the children or their parents would be very happy about that. But, you do have to be sensible about this. We talked about avoiding trouble, and that's probably about the best advice you can give. Now, there is a specific treatment that's given to reduce the rate of respiratory syncytial virus, and that's a series of injections that you get once a month for about 6 months through the epidemic season. Now, that's sometimes recommended by doctors. It's not universally recommended, and it probably reduces the rate of that particular virus, but it probably doesn't reduce the chance of you ending up back in hospital with other illnesses anyway. So it's a question of, that's the sort of thing you need to discuss with your individual baby's doctor about whether that might be or might not be recommended. It's certainly not universally recommended.
Another question we get, and we're coming to the end of our session today, is about flying with babies. And we get asked that question for parents who are very much hoping to take their baby over to see family overseas or just to go on a holiday, and they come to the outpatient clinic and ask us about that. So I guess there's a few things in there. The first is, when is it safe for any newborn baby to fly? And there are some restrictions around that the airlines have, so you've got to be careful to check your individual airline's policy on this. But even
what are those restrictions? That's not something I was aware of.
There aren't many.
Babies.
For some airlines, they don't mind even if the baby's only a few days old. For others, they say a few weeks. So you just got to check the fine print. So term well newborn infants can fly is the usual message. What about our sicker preterm babies, especially those that have gone home on oxygen with chronic lung disease? That's a lot trickier. Even if they're now off oxygen, we've got to be very careful about when we say it's safe for them to fly, and sometimes we even have to check whether it's safe for them to fly, doing altitude testing.
Yeah, I think if there's any doubt, that's the answer, and it's a question of the urgency of the travel, and if you can put it off until the child's bigger and stronger, that's probably sensible. But if you can't, then get the child tested, and what they can do is put them in the equivalent of the sort of altitude that you might get to. I mean, most commercial airlines travel at an altitude of 40,000 feet, but they're pressurised to more like 5,000 or 6,000, I think that's right. So that's a bit like living on the top of Mount Kosciuszko. That won't worry healthy people, but if you're somebody who needs oxygen all the time, that could be a problem. So if there's any doubt, get them tested to make sure they can travel at that sort of altitude for the length of time that the trip is. If it's a trip to Sydney, that's not so bad as a trip to Los Angeles, so 15 hours in the plane versus an hour in the plane. The duration is going to influence the response there.
We do find that many of our extremely preterm infants with chronic lung disease do need oxygen for flying in that first year or two of life, and we have to be very careful not to recommend, even if babies seem to be going well at ground level, we've got to be very careful about that because many of them do need oxygen when they fly.
It's certainly possible to deliver oxygen, usually with nasal prongs of some sort like that during the flight, and the amount of oxygen they get would be far more than what they need. So it's certainly okay to do that, but you need to know that they need the oxygen before they embark on the trip.
Mm-hmm. We're going to finish with one more question about asthma. There's been a few questions come through from Pravita and others about asthma medications and the question of whether they have any long-term effects themselves, because a lot of our preterm babies are ending up with wheeze or a diagnosis of asthma, and therefore they're on a preventer medication, a steroid-based medication, as well as a reliever-type medication like Ventolin. And parents are concerned, and we're not respiratory physicians who are experts in asthma, but parents are concerned, what are the long-term implications on being on those asthma medications for a long time? And I guess any steroid-based medicine that's taken in large amounts for a long time can have some side effects, but it's only if you take a lot, especially if you're taking the ones that into the stomach. Yeah.
So when I was looking after children in the 70s with asthma, we didn't have the inhaled corticosteroids. We only had the sort of medicines that you would take and would get to the whole body, not just the lung. And they would definitely cause long-term problems if you had to take them chronically. But the inhaled steroids, much lower dose, confined particularly to the lungs, seem to be much safer than what those corticosteroids were back 30, 40 years ago. I would suggest people worried about that discuss it with the doctor who's prescribing the corticosteroid. You and I don't do that, Brett. I've stopped looking after children completely. You only look after them over the first year or two, and you're not prescribing corticosteroids at that age. So this is really an older age problem. I can understand why parents will be worried, but talk to your doctor. I think that's the best advice we can give them.
All right, thanks, Lex. So we're going to end the session here today. Thanks so much to our partners, the Life's Little Treasures Foundation, and also the Murdoch Children's Research Institute, the Royal Women's Hospital, the University of Melbourne, and thank you particularly to all of the parents that have been online. There's still comments and questions coming through. We really appreciate you joining us today, and we hope it was interesting and useful for you. If we didn't answer your question today, we will try and keep an eye on that feed, and over the coming days and weeks start to respond to some of those questions. So please keep them coming through if you think of something in the meantime. So thank you, everyone. That's the end of our session today. And we look forward to seeing you again in future sessions run by the Centre for Research Excellence in Newborn Medicine and the Life's Little Treasures Foundation. Thanks, Lex.
Thanks, Brett.
Everyone.
Thanks, everyone.